it's a tumor that we might need to induce a more inflammatory phenotype. So this is a combination study. It's a Merck 365 study where I'm the PI for. It's an international study, 32 sites, where we're taking patients that are basically post-abiraterone and giving them pembro with enzalutamide, post-abiraterone or enzalutamide and giving them pembro, docetaxel, and post-docetaxel, pembro, and olaparib. This trial is fully accrued, but there is an additional cohort that will be added soon, and we will be reporting data very soon on it, probably at GU ASCO. There's some interesting findings. Of course, I can't talk about it now, or Merck won't be happy with me, but there's some potentially interesting findings. Gentek, of course, is doing the phase 3 ambassador trial. They jumped right on Julie Graf's data. The difference is they're not adding pembrolizumab or atezolizumab at the time of enzalutamide progression. They're treating patients right up front. So these are patients that basically failed abiraterone, might have had docetaxel before, and then they're randomizing them to enzalutamide versus enzalutamide plus atezolizumab, looking for a survival benefit there. All right, here's case 3. We need more than 5 answers, okay? 58-year-old gentleman presents for second opinion with metastatic castration-resistant prostate cancer. He's received all FDA-approved therapeutic options for widespread disease. ECOG performance has still 1. He wants more treatment. He wants a clinical trial. You take a family history, you find out he has a significant history of 3 members on his mother's side who all died of young with breast cancer. What should you consider now? And this is a real patient, okay? What should you consider now? Germline DNA repair gene testing, microsatellite instability testing, somatic tumor testing with next generation sequencing, referral to genetic counselor, all of the above. This is probably the easiest one of all of them, so I'm expecting we do real well. Yeah, we probably have like 50 answers, right? And everything's and that's the correct answer. Yes. And here's the thing is like germline DNA repair testing, yeah, this is important. We have a lot of patients that are inheriting this. I just talked extensively about microsatellite instability, somatic testing with next generation sequencing. I'll talk about that as well. And certainly if there's an increased risk of inheriting these germline alterations, a genetic counselor. So here's his, genetic tree. Here's him sitting here at 58. And in the old days, as a GU oncologist or urologist, there wouldn't happen to be any urologists out here, would there? Please declare yourself. I'm gonna start talking bad about you now. No, I'm just kidding. I love the urologists. They're close friends and colleagues of mine. But we used to just ask, do you have any family history of any GU cancers? Oh, no bladder cancer, no testicular cancer, and boom, we'd move on. But look at this. Right? All that breast cancer there. We would have missed all that in the old days. Now, this is for a general oncologist. This is less exciting. For a GU oncologist, we get excited about this, but you guys are used to doing this for breast and ovarian cancer all day long. So, but for, when you talk to the GU community, we're like, well, okay, well, we gotta ask more questions here. But look at that significant family history of breast cancer and at an early age. Collateral benefits. So this is the thing. Not only is there potential therapeutic benefit, but there's downstream cascade testing. Daughters referred to breast ovarian prevention clinic. One underwent a prophylactic procedure. Nephews for prostate cancer screening. Our hope is that we save a lot of lives downstream. Okay, it's not just about the patient sitting in front of you, but we can make a big impact this way. Therapeutically, we understand synthetic lethality. Okay, so you have somebody give a PARP inhibitor, will PARP repair single-strand DNA breaks. If you have somebody with normal cells with functional homologous recombination pathways, big deal, cell survives, right? But if you have somebody that's homologous recombination deficient, let's say BRCA2, now you take PARP out, and now you got synthetic lethality, a concept in the lab that actually panned out, right? So you're hitting 2 different nodes, and now you get synthetic lethality and cell death. Now, how common is this? Well, again, part of our Standup to Cancer metastatic sequencing study. We collaborate with Memorial, University of Michigan, Dana-Farber, and also in the UK with Johan de Bono. And we found 23% of men with metastatic castration-resistant prostate cancer harbor DNA repair alterations. It increased with disease progression. Probably half were germline, half were somatic. But then Colin Pritchard at our center did more work looking specifically for germline alterations, sequencing patients with metastatic prostate cancer, not necessarily castration-resistant, and found that 12% have inherited germline alterations in one of 16 DNA repair genes. age and family history didn't seem to affect mutation history. All right, if you have somebody with a significant family history, yeah, you got to be all over that. But if you don't, that doesn't mean that this doesn't exist. Okay, so what's the therapeutic implications? Well, PARP inhibitors. You know, Joaquin Mateo showed in this paper with New England Journal of Medicine, if you're biomarker positive with the DNA repair alteration, your response rates, your radiographic progression, your overall survival, way better when you give olaparib as a PARP inhibitor than those patients that don't harbor a homologous recombination deficiency. All right? This is busy. This is just a list of a lot of PARP inhibitor trials and some platinum trials on the end. We're now starting to not only try to get these FDA approved in phase 3 trials, we're starting to move this earlier into biochemical recurrence setting, into neoadjuvant studies. Along with Heather Chang, we're designing a study in SWOG right now to see if that comes to fruition through the NCTN mechanism. But there's a lot of excitement because the risk is a lot higher than one might recognize. As a matter of fact, for high-risk localized prostate cancer, it's a 6% risk of a germline alteration. And a 6% risk, now the NCCN guidelines even say consider testing. Okay, so it gives you consideration there. It doesn't recommend that you do it, but consider it. Let's talk about ASCO. So what happened at ASCO? Now, this patient population in this study was not enriched for patients with DNA repair alterations. It did not mandate that you have it. They took the theory that, hey, there's a lot of TMPRSS2, ETS1, ETS2 translocations in prostate cancer, and that this transcription factor downstream interacts with PARP, and if you inhibit PARP, then maybe you might get some activity here. So they took patients with prior treatment with docetaxel in Europe with metastatic castration-resistant prostate cancer, and then randomized them to abiraterone versus abiraterone plus olaparib. Now, in the U.S., we usually use abiraterone before chemotherapy, but in this study here, they did it for unselected patients. Of course, they did testing, but they selected patients without any bias, whether they had a homologous recombination deficiency or not. And they found a statistically significant improvement in radiographic progression-free survival, which really was quite shocking. I don't think anybody expected this. Now, here's their testing data. They did all types of testing. They did tumor testing, germline testing, and they were not consistent. They did cell-free DNA. It's hard to read there, but I think the summary is that 15% of this population, I think it was about 140 patients or so, 142 randomized patients, 15% of this patient population had DNA repair alteration, okay, that might predispose to outstanding response to olaparib. A little bit lower than what we might expect, which leads you to wonder about the sensitivity of their testing, number one, but also it's possible that maybe everyone's doing testing now and they find patients that are hit and they shuttle them towards another study where they're going to get a PARP inhibitor right off the bat instead of getting randomized with the chance of not getting one. So that could have been a possibility as well. There's going to be a randomized phase 3 study design. I think it's interesting, but I think it's early. I think the field's not completely sold yet. We'll have to see what happens. That's PARP inhibitors, but what about platinum? Well, Heather Chang from our center published this manuscript with multiple patients who had biallelic BRCA2 loss, showed dramatic responses to platinum chemotherapy, and now we have this trial ongoing, the Platinum study. If you have either a BRCA1/2 or ATM or other homologous recombination DNA repair gene, you get treated with docetaxel plus platinum, carboplatin, and then maintenance rucaparib PARP inhibitor. So we have multiple studies like this with enrichment. But here's where I think there's a really big impact. This, and you guys can write down this website if you want to. This is the Gentleman study. Okay, this is an online study where patients can take a little business card, go to this website, sign up online to do germline testing with color genomics of 30 different genes. Certainly all germline. They get a kit mailed to them. They do a cheek swab. They mail it back in. Okay, we'll get the testing. The doctor will get the testing if they check your name. Okay, results if they don't, and you don't find out, maybe the patient won't bring the information into you. But the whole point of this is with a 12% risk, if you ask a geneticist, what's the cutoff, when should you test everyone, they'll tell you 10%. Of course, our healthcare system isn't ready to support that, so we're doing this, 2,000 patients everywhere, anyone with a U.S. residence except for New York. They have weird laws there, but they won't allow it. It used to just be Washington State, but now anybody can do this. So you guys could jot this down and offer this to your patients. And you know, if you find it again, the cascade testing could be very important to save a lot of lives. prostate cancer. Here's the prostate cancer genetics clinic that Heather started. She's now counseling multiple centers on starting this. She recently helped the MD Anderson start one. Israel, they want to start it for their entire healthcare system, and so they've invited Heather to help them start this. But basically, we have a high-risk prostate cancer genetics clinic. We're looking at patients with family history, known BRCA1 or linked carriers, early diagnosis, male breast cancer. She wants to see these patients. And here's the deal, is that, yeah, we're going to do testing when insurance will pay for testing. And yes, she has a genetic counselor working with her in that clinic that's outstanding for the patients. But there are a lot of patients where they do BRCA testing and they don't find anything. And that's where the research is going to be important, because there are tons of cancer predisposition genes we're just not smart enough to know about yet. And so Heather's working closely with Mary Claire King, and they're looking for basically families that have a lot of different cancers, that there is no clear cancer predisposition gene, and I'm sure they're going to define many ones. Okay, case 4. 62-year-old gentleman, history of radical prostatectomy, Gleason 5, prostate cancer. I should have said grade group 5. That's the new thing. We're not using Gleason anymore. But develops biochemical recurrence with a rising PSA 1 year later, received salvage radiation, 6 months of ADT, and PSA nadir is undetectable but starts to rise 6 months after completion of therapy. Patient gets intermittent ADT, but after 3rd cycles, PSA starts to rise. With the castrate testosterone level, he goes on to continuous ADT. PSA is now up to 7.4, PSA doubling time 4.3 months, restaging CT and bone scans, unremarkable, asymptomatic. What do you do now? He has M0, castration-resistant prostate cancer. Apalutamide